did there come a time when you met directly with Ms. Hurd?
Yes, I did. So in conducting my evaluation, I met with Ms. Hurd on 2 separate dates, December 10th and December 17th, 2021.
Approximately how much time have you spent with Ms. Hurd?
So the evaluation, we spent 12 hours directly with one another. However, there were more hours involved in the evaluation with some breaks. So we spent 7 hours together on the first day, December 10th. Not necessarily together because there was a 1-hour lunch break and about a half hour with breaks split up through the day. And then on the 17th, we spent a little more than 8 hours in the evaluation from start to finish with a 1-hour break and another half-hour of breaks distributed throughout the day.
As a result of the work that you performed, did you form any opinions with respect to Ms. Hurd?
I did.
What were those opinions?
The results of Ms. Hurd's evaluation supported 2 diagnoses, borderline personality disorder and histrionic personality disorder.
What is a diagnosis?
A diagnosis is a way that that psychologists, psychiatrists, anybody in the mental health field thinks about a disorder. It helps us to communicate a set of symptoms that a person is experiencing, and along with that set of symptoms, it tells other professionals a lot about how those symptoms might have developed, how that person might behave, perceive the world. It also drives treatment. The real purpose is to determine what sort of interventions will be most effective for the person.
Yeah. Previously, you made reference to, I think you called it the DSM-5. What's
Yes.
that?
So the DSM-5, that stands for the Diagnostic Statistical Manual, version 5, and that contains every diagnosis we use in mental health, and it's the authoritative manual of mental diagnoses.
Is performing diagnoses something you typically do in your line of work?
Yes.
Thank you. So you referenced 2 personality disorders. What's a personality disorder?
To understand a personality disorder, I think it can be helpful first to kind of define personality. So personality, something we take for granted, but these are the traits, the characteristics, the way we think, we feel, and we act that make us who we are. And these traits are pretty stable over time and across situations. We might, be sure to mind our P's and Q's when we're meeting somebody new, but overall, if somebody were to describe us or if we were to describe ourselves, we have a pretty good sense of who we are. Sometimes an easy way to think of it is imagining how you might describe a brother or sister or a child if you have children. Their personalities are pretty clear to you. A personality disorder is some sort of dysfunction in those enduring traits. So as opposed to other types of mental illness, when you think about something like depression, that's episodic. It comes and it goes, and when it's treated with medication, it can pretty much be completely mitigated or minimized in a person's life, and their personality is still there, separate from the depression. When we have a personality disorder, there are going to be disturbances in several different areas that are visible in almost all different facets of their life.
Is there a manner in which personality disorders are commonly diagnosed?
Yes, so they can be diagnosed in a treating environment. Treating psychologist or a therapist or a psychiatrist simply does a diagnostic interview, which involves assessing multiple areas of a person's history back down through childhood.
I'm going to stop you for a second.
Yes.
What's a treating environment?
Sometimes I'll slip into these words, I apologize. So a treating environment in therapy, if somebody is going in for treatment, the mental health provider will ask them questions to find out what sort of symptoms they've experienced and what sort of things have occurred in their life that might be consistent with these disorders, or rule out these disorders, prove that there's no reason for these disorders to be considered. They might also pay attention to their observations of the client over time and new information the client provides them. The most reliable way, however, to ever come about a diagnosis really is through a comprehensive psychological assessment. And I might use the words assessment, examination, testing interchangeably. They all mean the same thing. It's combining information from multiple different sources. One main source is psychological testing using validated objective measures. That means that they've been tested, they've been shown to be accurate for testing what you want to test, and in the environment you're testing. So there are measures specific for court environments where someone might respond differently. You integrate that with the same interview I was telling you that people would do for therapy. We do that as well. And then in a courtroom setting, you're going to look at all the legal records, all of those documents, corroborating information to sort of check your hypotheses that may be developing, and also check against the examinee's statements to confirm whether you have enough evidence of a certain diagnosis.
So what's a clinical interview?
A clinical interview is a very comprehensive interview. It includes a person's entire life history, as well as very specifically looks at any symptoms they might have. This can start as far back as birth. You might find out if there were any issues with their delivery, any genetic issues, any intellectual issues. How did they do? What was their home life like? How was discipline handled? What's their relationship with their primary caregivers? Were they raised by an aunt, an uncle, their parents? How many siblings do they have? How do they get along with their siblings? How many times did they have to move? Was there any abuse? Did they have any really significant life experiences that come to mind when they think about their childhood? How were they as a student? Did they need special services? Did they get in trouble at school? And you do this, you continue on high school. What were their hobbies? Did they play sports? How many friends did they have? Did they have any trouble keeping those friendships? Then you get into adulthood. Did they go to college? Did they not go to college? How come? What sort of jobs have they held? How did those jobs go? How did they end? That's always an important question. What sort of romantic relationships have they been involved in? How do they identify sexually, culturally? Let's see, what else? What sort of symptoms have they experienced? You go through the entire gamut of some of the main symptoms. You might screen for depression, any disorganized thinking. That means thinking that isn't necessarily in touch with reality, and any current distress they may be having today.
How did you conclude that Ms. Hurd suffers from the personality disorders that you identified?
So there was information that supported it from multiple sources. I conducted testing, including one of the main tests that I used. She obtained scores that were consistent with those diagnoses, and then I also, there was evidence of those diagnoses in her records and in her self-report.
Okay. You indicated, you were talking about emotional reactivity. What, if any, emotional reactivity did you observe in your review? And let's do this one at a time.
Okay. So there were a couple indications to me. First, I can sort of think about it with the treatment records. So particularly Dr. Cohen-Connell's. Am I getting the name right? I feel like for some reason in my mind I might have just reversed it. But Dr. Cohen's records, I did reverse it. He actually refers to this reactivity quite a bit and to Ms. Hurd's temper. And that temper, it's often branded, or being hot-headed, is really characteristic of borderline personality disorder. As is their very charming, personable nature. This is a disorder of contradictions. In Nurse Filati's notes, I thought there was something interesting. She references a night when they're out to dinner, I believe in London, and she provided positive reinforcement to Ms. Hurd because Ms. Hurd had been disappointed by a mistake made by the server, and it sort of references how previously she might have criticized the server or become upset by that, and that she didn't this time, and so that had been some sort of a step forward. And there was also an indication actually in Dr. Hughes's, Dr. Hughes is a forensic psychologist who had been appointed by Ms. Hurd to conduct as an evaluation as well. In Ms. Hughes's interview of Ms. Hurd disclosed that she had cut her arm in the past, which is a typical reactive type thing somebody with this diagnosis can do. It's one of the symptoms. And that's sort of all I can think of top of my mind from the treatment records. Moving into some of the declarations or deposition testimony, what struck me was Ms. Raquel Pennington's testimony. She's a former friend of Ms. Hurd's, and she told a story about, I suppose they were shopping for Thanksgiving accoutrements, something to prepare for Thanksgiving, and Ms. Hurd struck her in the face, sort of out of the blue, which is, I thought was interesting, because that is one of those signs of borderline personality disorder where if a friend or a loved one isn't meeting your needs in that moment, people with borderline personality disorder can be very caring in their relationships as long as their needs are being met. They feel that their needs should be met when they want them met at a specific level, and if they're not, then that anger, that sense of harm causes them to react. So the striking Ms. Pennington, per Ms. Pennington's report in the declaration or the testimony, I thought was pretty consistent. And then Ms. Hurd's own self-descriptions.
Okay, I'm gonna ask you a question about,
Sure.
You indicated Ms. Pennington was a former friend of,
Yes.
of Ms. Hurd. Is there a relationship between borderline personality disorder and intimate relationships?
Yes, so the instability definitely translates to their relationships. You'll see relationships start very intensely. People will, somebody with borderline personality disorder perceives the relationship as extremely close. This pattern of idealizing and devaluing is definitely at play. They do this with their lovers and also with their friends. And so this might be the perfect person, their perfect soulmate friend, perfect soulmate partner, and their engagement in the relationship is very alluring, very charming to the other person. And so initially everything seems great. But what occurs is that reality sets in. People are not perfect, even when we have a lot in common with them. Whereas most of us can accept somebody as a whole, somebody who has a little bit of flaws, and still think this is my great friend who always constantly running late for dinner. The person with borderline personality disorder, things are in these extremes, this black and white, we call it splitting. And so that person goes from being idealized, the perfect person, to dumpster. They are totally devalued. They are the worst friend. They don't care anything about me. I have better people around. And then there will be a repair, because the person with this disorder does feel remorseful after they have these reactions, angry, tell their friend off. But over time, it wears away at these relationships. And so what you'll usually see is many, many transitions in their friendships over the years, people who have sort of fallen by the wayside, who were really very close-knit at one time, and then, but there's not a lot of consistency in the long term. You'll also see that with their intimate relationships, many, many relationships, but none that are particularly long-term.
How does borderline personality disorder relate to identity issues?
So again, that instability also travels toward identity. And when I was describing personality earlier, I was talking a little bit about those traits we have that help us know who we are. When you have borderline personality disorder, that actually is not something you understand. So people with this disorder actually take on the identity of the people they're spending time with because it's comforting. It's very uncomfortable to not know who you are. Some people with this disorder will describe a feeling of emptiness when they feel like they've been abandoned because now they don't know who they are in the world. And so when somebody with this disorder is going through that initial enmeshment phase with new people and they're idealizing them, they often will take on the identities of those people. So they may mimic them in a lot of ways. They might mimic the way they dress, their interests, the way they talk. And for this reason, the people around somebody with this disorder kind of from the outside may feel like, wait, I thought you were this way, now you're advocating for this, and this is your new main interest in life, or the thing you're throwing yourself into all completely. Music tastes might change, hobbies will change, the way they dress.
Okay. In addition to borderline personality disorder, I understand that you diagnosed another personality disorder. What's that?
So histrionic personality disorder, and these are really two sides of the same coin. They belong to the same cluster. We call these clusters. It's a way to organize personality disorders in that DSM. And this cluster is described as the personality disorders that are dramatic, erratic, and emotional. Okay, so unpredictable, but really having to do with emotions and relationships. They're very similar. Whereas I was saying that borderline personality disorder, a lot of the key features that you're going to notice are instability. When it comes to histrionic, a lot of the key features are going to be drama and shallowness. Similarly, with borderline personality disorder, there's this underlying drive of avoiding abandonment. With histrionic personality disorder, that underlying drive is to always be the center of attention. Because if you don't have that attention on you, it feels similarly to borderline personality disorder. You feel pretty empty, like you don't have that sense of being or of value, okay? So whereas borderline personality disorder might have more of the visible reactivity if somebody seems to be leaving, with histrionic personality disorder, what you're going to see is extreme discomfort with not being the center of attention, extreme efforts to be the center of attention, and when they feel that they're not the center of attention, you will see some strange things, making up stories to try to get attention, often taking on a victim or princess role. Those two roles in particular are pretty consistent. Seeking caretaking. Borderline personality disorder is similar because with borderline personality disorder, these shifts of identity and the splitting, you might see somebody go from being, in the DSM it describes it as a needy supplicant of help, seeking the perfect caretaker, to suddenly being the avenger against injustice or thinking that their partner is a terrible person. With histrionic, what you'll see is somebody who wants to be the center of attention, has sort of that impressionistic speech, very flowery, very enthusiastic, but nothing's really being said. The moment your attention wears away, because they're so demanding for attention, that's when they might take the victim role or the princess role and even make up stories. Sometimes those stories are to bolster the victim role. Sometimes those stories are just to make them look more interesting or accomplished in their mind so that they can get respect and attention that way.
Is there a relation between histrionic personality disorder and attractiveness?
There is, strangely, and this is always one of the trickiest things to talk about because how is that a symptom? But characteristically, people with this disorder are very, very interested in looks, but more importantly, they utilize their looks to get that attention, to get that respect that they're seeking. And so this type of a personality might be flirtatious with everybody. Characteristically, they actually couldn't even be subtly, and when I say flirtatious, I'm not talking overtly sexy, but kind of inappropriately flattering. Sometimes they act in a kind of a girlish way to be cute and to engender attention. And this will even occur in their therapy relationships as a way to sort of avoid getting negative feedback or criticism. Oftentimes they'll bring the therapist gifts or be distracting if they engage in therapy because they just don't want any criticism. They want the therapist to like them.
Does the intelligence of the affected person bear on the manner in which these disorders present?
Excuse me, I choked a little bit water. Yes, and I think one way to think about it that's probably a little more accurate than just intelligence is, in psychology we would describe this more as sophistication. So street smarts, so to speak. The way, for instance, I've had many clients who have borderline personality disorder who are messy and really clearly suffering, and they might be difficult and all over the place and yell at you in the middle of session, but it's so, it's not tailored. It's so much easier to work with because of that just openness and rawness of it, genuineness. Sometimes you'll have a more sophisticated presentation. There are 9 symptoms and only 5 have to be met. So there are a lot of different combinations and different ways it can present. And sometimes you'll have more of a petulant version of this, where it really shows when you push the button and you're kind of, whoa, what was that? So somebody who's really productive, high functioning, successful, and you get to know them and you think they're fantastic because they're so interested in you too. And you might not realize it, but they're mimicking you perfectly. So you're really just kind of falling in love with this new friend who is being you. But then all of a sudden, you say something that they think is offensive, and you can't, even in your wildest thoughts, understand how that could have offended somebody, but their reaction is so strong that you kind of buy into it. Gosh, maybe I did say something offensive, and you feel bad about it. So that sophisticated version, they can be a little bit more calculated in the way they present. They tend to kind of hit you where it hurts a little bit more, and they can be actually very, very destructive.
What conclusions were you able to draw about Ms. Hurd's sophistication from her testing?
Well, from her testing and from her presentation, she was very likable, but her testing in particular showed that she approached it in a manner that, remember I told you about those scales that are pretty neat. She approached it in a manner that very clearly minimized any psychological dysfunction, not just that, but really presented herself as free of any problems. And she did so in a way that was very, very sophisticated, not obvious, by responding to questions that most people might not notice were trying to detect them.
How did you determine that?
So that's based on a particular scale on the MMPI-2 that is designed specifically to detect a type of responding that's a little bit more clever, a little bit more sophisticated, minimizing problems in a way that most lay people probably wouldn't understand, and even providers, very difficult to detect.
You mentioned that one of the characteristics of borderline personality disorder is emotional reactivity. How might that present in an intimate relationship?
So I think it probably presents mostly, or you'd see the bulk of it in intimate relationships because of that regular interaction and the desire for your partner to meet all of your needs, to be the perfect caretaker. Also that the hallmark of the disorder with the splitting, so idealizing, devaluing, and the perceiving of all sorts of neutral events as somehow demeaning or disrespectful. It's regular escalations of anger, frustrated complaints, criticisms of your partner. But because the person with borderline personality disorder, first of all, they're more sensitive to things, they feel distress more strongly, and then that distress lasts longer. So these types of blow-ups go on forever, and they're very cyclic. It feels like you just can't get a resolution, and eventually the partner will try to leave, will want to leave to take a break. It wears them down, and that's when the borderline might explode and act very aggressively or violently to try to prevent them from leaving.
In addition to diagnosing Ms. Hurd with these 2 personality disorders, did you form another opinion about Ms. Hurd's mental status?
Yes, so go ahead.
If the answer to that is yes, I'm going to now ask you,
okay,
what
yes,
was that?
I did.
Okay, what is it?
So in addition to looking for Ms. Hurd's general mental status any psychological issues that were present. I very specifically was assessing to determine whether post-traumatic stress disorder was present, and it was not.
How do you know that?
So first of all, from multiple information sources, right? So I was integrating the interview, my review of the data, the case records, other people's testimony, her treatment records. And then I also conducted, in addition to the MMPI-2 and looking at that data, I also conducted the clinician-administered PTSD scale, the CAPS-5, which is the gold standard PTSD assessment developed by the National Center for PTSD, shown to be valid, accurate for use not just with service members, but also with civilians, men, women, all genders, and also all ethnicities, and then also specifically for use in a courtroom setting.
How do you conduct the CAPS-5?
So the CAPS-5 is a standard interview. What that means is that it's an interview with very clear questions that are scripted, and you ask those same questions every time you test a person. So because you're doing that, you're actually taking something that would typically be kind of subjective, an interview with somebody, and you're making it more objective. When you ask those same questions in the same way every time somebody's assessed with this, now you can apply a scoring protocol and actually score their responses.
As a result of applying those protocols, what did you conclude?
Ms. Hurd did not have PTSD, and there were also pretty significant indications that she was grossly exaggerating symptoms of PTSD when asked about them.
How did you make that latter conclusion?
So one of the strengths of this test, as I mentioned, the important thing about any test used when you're doing an evaluation in forensics is to make sure that the person is responding accurately. And this test does that by not just asking people whether they have a symptom, but asking follow-up questions that draw out very detailed accounts of every single symptom of PTSD. And when you're really familiar with this disorder, which you need to be to administer this test, there are nuances in the way a person will describe their symptoms that have been shown repeatedly to indicate exaggeration or faking. There are also indications when somebody is clearly giving you a genuine response.
Okay. What, if any, symptoms of PTSD did you observe in Ms. Hurd?
So there are 20 kind of core symptoms that somebody can manifest with PTSD. You don't have to have all of them. Ms. Hurd initially said that she had, in the first question, you say, do you ever have this, before you get to the more nuanced follow-up questions. When I asked that first question on each item, she initially said, yes, I have that, to 19 of the 20 symptoms. That's not typical even of somebody with the most disabling form of PTSD. When we eventually sort of dialed it down, she had 3 remaining symptoms. And having symptoms of any disorder is common for all of us. Some of us struggle with sleep. Some of us get anxious. It could be several different disorders. It could just be that you have this struggle in your life. But she had 3 specific symptoms that I scored as present. Off the top of my head, I might miss one, but one was sleep disturbance. So she reported that she has frequent nightmares. Another one was that she said that she tends to have a startle response. So if she gets startled or surprised, she tends to stay in sort of a hyper startle mode for quite a while. And that's consistent with a couple of things. It can be consistent with PTSD if other criteria are met. It's also consistent with childhood complex trauma, which is something that can occur when your brain is forming. If you constantly feel unsafe, if your parents are abusive, or if they're not present, if you're neglected, you can develop certain physiological responses that can stay for a long time in your life. So I noted that seemed like a very genuine, accurate account where she stays in this state of kind of hyper arousal, has a hard time calming down if she gets surprised.
You mentioned nightmares as well.
Yes.
Did she recount for you the nature of the nightmares?
So they were vague. she indicated that she has recurrent nightmares and that she feels as though she's being held down. There was some conflict in that account because even though that could be a PTSD symptom, it is fairly vague, but I still scored it as present. And in her initial treatment with with Dr. Bonnie Jacobs, which I believe started before she began dating Mr. Depp, she had indicated to Dr. Jacobs, according to Dr. Jacobs's notes, that she was having repetitive nightmares back then and that they were related to her childhood trauma. And so that came up several times in the notes. Dr. Jacobs kept mentioning that.
Thank you. What is feigning?
Feigning is essentially faking or exaggerating symptoms that aren't present.
Does the CAPS-5 control for that?
It doesn't necessarily control for it. It can expose it by drawing out the...
How does that work?
Because you're not just simply handing the person a checklist that says, here are all the symptoms of PTSD, why don't just check off the ones you have, which clearly if you're trying to look like you have PTSD, you would just check them all. The CAPS-5, because it requires them to describe in detail how they experience the symptom, where it shows up, what it looks like, what sort of examples they can give you, how many times it's happened in the last couple weeks, how many times it's happened in the last month. By the end of each symptom, you've gotten a very good picture of a couple things. One, does it meet the definition of the symptom? Are they getting it right? Is this actually the symptom, or are they kind of confusing this with something else? Number two, are they giving you very vague accounts? Are they giving you kind of a stereotyped idea of what the symptom is based on media or movies or something that actually is completely different from genuine experiences of this symptom? Or are they giving you a very genuine, heartfelt, sometimes minimizing, but it's ticking all the boxes, their mannerisms while they're describing it, the actual very specific, very nuanced, symbolic ways they're describing it. A lot of times it smells, it sounds. That all appears in genuine accounts, and it's something that people really get wrong when they're feigning.
All right. In addition to your conclusion that Ms. Heard does not have PTSD, did you make a conclusion with respect to her symptoms?
Yes, actually I did. So, just because somebody doesn't have PTSD doesn't mean that they weren't harmed psychologically by whatever is being alleged. In this case, Ms. Heard is alleging that she was psychologically harmed and that she suffered PTSD because of abuse that she alleges occurred by Mr. Depp. So the MMPI-2 is helpful because it shows you kind of everything, any other symptoms. And then in Ms. Heard's own self-report and her prior treatment records, I knew that she had reported to me that she had had some other symptoms. So now what becomes really important is determining, and let me clarify one thing here, not so much a diagnosis, but did she start to experience symptoms during the relationship and after? Did they worsen after? Or could these types of symptoms or reports be explained by other factors? A, by feigning, B, by pre-existing conditions, or C, by other stressful life events that might have occurred. So the main symptoms that I was looking at didn't meet criteria for PTSD, right? There was also substantial evidence of this sort of emotional dysregulation, emotional disorganization, the shallowness, the dramatic affect. Now, when you have a lot of childhood trauma, you can actually have some similar type presentation in adulthood. There are some differences though, but also that's not something that would have occurred after this relationship. So now I was looking at, are there indications that these types of things that she's described, this transient anxiety, the issues with sleep, were these there prior? And sure enough, Ms. Heard, in her own self-report, stated to me that when she first got to LA, she was seeking treatment for, in her words, blanket anxiety and depression. She also reported that she was taking medications. In general, none of them were helpful. That's actually very typical of borderline personality disorder. Medications typically aren't very helpful for somebody with the disorder. They really need an intensive, lifelong type of therapy, which is not necessarily as relevant to this. But interestingly also, people with borderline personality disorder often respond really positively to stimulant medications that are given for ADD or ADHD. And in one of Nurse Filati's notes, she reported that Ms. Hurd told her that none of the medications were working for her except for one Provigil, which is often prescribed as stimulant medication. And I just thought that was interesting and sort of consistent with more of these lifelong personality disorders that aren't necessarily caused by a harm by any allegations, but have been there and will remain there typically. The other issue, so the anxiety, she had already indicated that had been there prior, but the form of the anxiety. So looking at Dr. Hughes's testing and then also looking at the scores on the MMPI, when you look at all these little combinations of the scores, you can actually learn a lot about, is the anxiety related to an event, or is this more a person who tends to be an anxious person regardless of what's going on in their life? And somebody might describe them as a worrywart. And the scores, the little combination of scores that she obtained actually indicated that it was the latter, that her anxiety tends to be separate from events and more just kind of a constant, and it comes and goes, but it's more of a trait.
I have no further questions for this witness.
All right. Maybe why don't we go ahead and, Ms. Bray, go ahead and have our lunch break. It might be a good idea to break it up there.